All right, good afternoon. I'm Dr. Dale Bratzler. I'm the Chief Quality Officer here at OU Health, and I'm also the university's Chief Code Officer. I'm going to give a brief update of where we're at with the numbers today. I know many people get to see those routinely, and then just talk about a few issues that have been in the press this past week, the medical press, particularly around some of the new recommendations, both for vaccines, both in pregnant women, and also for booster doses. So, as of today, and by the way, there will be a handout that will be distributed that has all the information and some references in case you want to check the sources. So right now, Oklahoma ranks ninth in the nation in terms of daily new cases. We're at 52 new cases a day on average. Again, we've dropped a little bit. Missouri has fallen off the list of the top 10, which is interesting because Missouri truly was an epicenter of the pandemic in the United States for some time, so they've dropped down. I included a map that just shows the hot spots in the country, and clearly Louisiana is the hottest spot in the nation. It has the highest rate of new cases per day, the widest community spread of the virus. Florida would be second with a very substantial community transmission, and I think many people saw the requirement for the home opener for the Sooners. The opener, the first game of the season for the Sooners, which will be at Tulane, where they are requiring either proof of vaccination or a negative test. And that's because Louisiana is in real trouble right now with respect to COVID-19. If you look at the CDC's report on just the national ranking, Oklahoma currently ranks 8th in the nation in terms of new cases per week. So the State Health Department released data at around 11 o'clock this morning. There were 2,800 new cases of COVID-19 in the state today, an increase in the number of deaths. And again, I just want to highlight in the handout, it'll show that we're at the same level of cases today that we were on November 12th of last year. And we're just opening schools this week. So I don't think we're at our peak at all at this point, because I think most of us expect that as schools reopen, as kids come together, particularly if they're unvaccinated, that we will see an increase in the case numbers over the next week, 10 days, or 2 weeks. The 7-day rolling average now is up to 2,122 new cases a day in the state, and that's following a very steady trend upward that it's been at for the past 14 days. I think the thing I'm most concerned about in the data is hospitalizations. Another substantial increase today. 1,326 Oklahomans are in the hospital. 27% of those are in ICUs. 360 people in the ICU. I was looking at data earlier today that looks at, what is the survival rate if you have COVID and end up in an ICU. And if you look at published data, it's in the 50% range. Now, we may be better now than we were when some of that data was published, but the reality is if you're sick enough to get into the ICU, I think we're going to continue to see some COVID deaths in Oklahoma. And I think most of you are aware that on the community transmission map, most of Oklahoma is red. There are a few orange counties. There are a couple of counties out near the Panhandle that have lower rates of community transmission of COVID-19 at this point. I put one more graphic in that I looked at this week, and that's hospitalizations by age group. This is data that comes out of the weekly epidemiologic report. So if you look at the first week of August, 62% now of all hospitalizations for COVID are in people below the age of 65. About 38% are people that are 65 and older. Clearly, this remains a disease of the elderly. However, we're seeing more young patients being admitted to the hospital, and we're even seeing pediatric admissions in Oklahoma. So again, I think we need to take this very, very seriously. We're dealing with a different virus. It infects everybody and may cause more severe disease. So just going to a couple of things that have been in the medical news this week. I think most are aware that yesterday the FDA approved Yesterday the FDA authorized a booster dose of the COVID vaccine for immunocompromised individuals. That is in particular patients who have had organ transplants and patients that take immunosuppressive drugs for things like cancer, rheumatoid arthritis, or other diseases where they're taking medications that suppress their immune system. It might also include HIV patients who are often immunosuppressed. So this is the first formal recommendation in the United States for a booster dose in anybody in our population. The second thing I wanted to talk about briefly, I haven't heard a lot of press about, but I think it's important to remember that there was a recent change in the approval for monoclonal antibodies. Monoclonal antibodies, basically, we take a patient who is an outpatient, we give them antibodies against COVID-19 before they're sick enough to get in the hospital. We don't do it for everybody, but if we have an older person or a person that has an underlying medical condition like kidney disease, diabetes, lung disease, that might put them at greater risk of complications if they get worse, then we can give that person monoclonal antibodies. And historically, we've only been able to give it to people who have had a positive test for COVID, who we were concerned that might be at risk of going into the hospitalization. I will point out that monoclonal antibodies are one of the only effective therapies that we have for patients who are not in the hospital with COVID-19. There are no other treatments that have been proven to be effective at this point. But most recently, the FDA made a new approval for post-exposure prophylaxis. So the scenario is you live with somebody, they came home, suddenly they test positive, and you've been exposed to them. And if you're a person who's in a high-risk category, and I've put in the list of high-risk conditions, and it's a long list, but if you live with somebody or if you've been directly exposed to somebody who's positive for COVID-19 and you have high-risk characteristics for the risk of COVID-19 and the complications from COVID-19, you can get post-exposure prophylaxis even though your test is not positive. So the drugs, the monoclonal antibodies, can be either given intravenously or by 4 shots subcutaneously. But it's an underutilized therapy that might help us reduce the number of people who need to be hospitalized if we can identify early those people who've been exposed to somebody that has COVID and those people that have severe underlying conditions that will put them at risk. It's only approved for kids, for people 12 years of age and older. You have to weigh at least 88 pounds to take the therapy, but again, it's exposure, post-exposure prophylaxis. It is not for formal treatment of people that are sick enough to be in the hospital. The list of high-risk individuals is pretty long. One other point I want to make is COVID and pregnancy. This week, the CDC came out with a strong recommendation that patients who are pregnant get the COVID vaccine. I want to make it absolutely clear there is no risk of fetal abnormality from the COVID vaccine. But a very interesting study that I think helped drive the CDC's decision was published from 499 U.S. academic hospitals, had 869,000 women who came into the hospital to deliver a baby. And in that study, and this is compelling, women who got COVID or had COVID and came in to deliver a baby were 15 times more likely to die, 14 times more likely to be intubated, put on a ventilator, and about 6 times more likely to be admitted to the intensive care unit. Now, those numbers are relatively low because most pregnant women do well, but it was very compelling data that COVID in pregnancy is not good. It increases maternal complications and it increases complications for the newborn. So it is very, very important that pregnant women be vaccinated against COVID-19. That is a formal recommendation of the CDC. It is a formal recommendation of the American College of Obstetricians and Gynecologists. And then lastly, I've mentioned this a couple of times this past week, but I wanted to highlight that there were 2 studies that have been published, and I've given references that look at people who have previously had COVID. Are you protected against reinfection? And the good news is that there's some protection, but the other news is that if you get vaccinated after you've had COVID, you'll have a substantially stronger immune response, and it dramatically reduces your risk of hospitalization and complications. So there was a nice study done in Kentucky where they looked at people who had previously had COVID, and then they compared those that had gotten the COVID vaccine to those that had not. And being unvaccinated was associated with 2.3 times higher risk of reinfection than people who just had had previous COVID and did not get the vaccine. So the vaccine reduced the risk more than half of getting reinfected if you previously had COVID-19. So very, very important to understand that we do recommend, it is a formal CDC recommendation that all people who have had COVID-19 get the vaccine, because now we know that it provides additional protection. Lastly, I put a graphic in that comes from an article that was published in Nature. It's interesting. It's very difficult to read on the handout, but I gave the reference, and it's a nice meta-analysis of long-haul syndrome. And basically, they've identified 50 different long-term effects that can occur from having COVID. Again, you don't want to get COVID because 30% or so will develop long-haul symptoms, and they can be substantial. So those are the important points I wanted to make today. I'm happy to answer any questions.
So let's start with, if someone is experiencing or they're just not feeling well, what is the point where you're like, you think, well, I better stay home, I better go get tested, or do you just, if it's just allergies, you just go out? I think, I don't know what to do.
Yeah, so the question is related. You have some of these non-specific symptoms. And remember, there are all sorts of symptoms that a person infected with COVID can present with, such as headache, runny nose, sore throat. Oh yeah, the same things that you might think it was an allergy. I recommend that people have a high index of suspicion. If you're concerned at all, if you think that you could have been exposed or you've been out in public and now you have symptoms, headache, sore throat, fever, runny nose, any of those, certainly shortness of breath or cough or GI symptoms, go get a test done. And it's not hard to find a test. You can do a simple at-home test, an antigen test right in your home. You can buy them at any pharmacy or Walmart, places like that. If it's negative, those tests are pretty good if they're negative. If they're positive, then you need to go and get the formal PCR test. But we strongly encourage you to get tested. The more people that get tested, that we identify that are positive, then we can keep them from interacting with other people and slow the spread of the disease.
Is there a big, you said if they're negative, you can kind of trust that. So, but it seems like there's a wide variety of testing. So I know one place that's doing just throat swabs, and then you've got the traditional where they go up to get brain matter, and then you've got the I saw at CVS, you drive up to their window and they talk you through doing it yourself in the car.
Right.
So
yeah, so the only study I've recently seen that looked at whether different types of specimens were useful is saliva testing. If you have no symptoms at all, if you're just doing a test because you were exposed to somebody and you have no symptoms, saliva probably isn't very good. And some type of nasal swab is probably better. There's not a lot of strong evidence that the nasopharyngeal swab, the one that goes all the way up into the posterior portion of the pharynx, or the anterior nasal swab where you're just swabbing the anterior part of the nose, is much different. And that's particularly true with the Delta variant because you have so much virus with the Delta variant that you can find it almost anywhere you look for it. So I don't think it makes a whole lot of difference if you do the anterior nasal or the nasopharyngeal swab. Maybe not saliva if you're completely asymptomatic, because there are studies that show that saliva is not as sensitive in those particular patients. But again, if you have any symptoms, you've been around people, you've been outdoors, in indoor settings around other people, then please consider getting a test done.
Okay. Can anything stop the current surge? I mean, considering the real world conditions of our current vaccination and mask wearing rates, is there any hope to stop the surge?
So that's a great question. Is there anything we can do to stop the surge? Clearly, if we could just overnight get everybody vaccinated, we would dramatically reduce the number of cases, and in particular would dramatically reduce the number of people in the hospital. So getting vaccinated, I think, is the most important strategy, and I think we need to do whatever we can to encourage people, to incent them, to make sure they understand the risk of COVID-19 and getting as many people both tested and then vaccinated, as possible. I think that's going to be really, really important. Wearing a mask, I said it before, is a universal, effective mitigation strategy against all variants of COVID-19. So if you go out into public, particularly if you're indoor settings or around a lot of people, I still strongly encourage you to wear a mask, both to protect yourself, but I believe personal responsibility goes beyond doing what's best for you. It's your, as some people have said, it's your societal obligation to protect the people around you, because you don't know if you're infected or not, and even people that are fully vaccinated can on occasion get infected with the Delta variant and can spread it. So wear a mask when you go out into indoor settings, and when you're around crowds of people.
And kids going to school, so many of them can't get vaccinated yet, so many haven't gotten that can. Just reiterate again how important the mask is.
Yeah, so the question is about children going back to school. So we know that in the 12 to 17-year-old age group, only about 1 in 5 is fully vaccinated, and that anybody obviously below the age of 12 is not eligible to be vaccinated. So there, the only mitigation strategies include wearing a mask, physical or social distancing, and hand hygiene. Those things are all important to help slow the spread, quite frankly, of any respiratory disease, RSV, influenza, and COVID-19. We know they work. We know they clearly work to slow down the spread of disease. I just strongly encourage parents to teach your kids that, why it's so important. And again, part of this is the societal implications of protecting the people around you.
The implementation of emergency rules will kind of help maybe solve some of the hospital problems?
Yeah, I have not seen the details of the emergency rules that the commissioner talked about. I understand that they do include some language that would allow hospitals more flexibility in terms of space and space changing within hospitals. Remember back in December, January, and February when we had such a huge surge of COVID-19, many hospitals had to convert different parts of their hospital to COVID units and even change some of the bed licensure requirements to do that. So it's my understanding just from the comments that some of that may be spelled out in the emergency rule, which could free up some hospital beds. And I know the state is working on ways that they might be able to help the nursing shortage, but that's the biggest limitation right now, because even if you have beds available, if you don't have nurses to keep the beds open, we're not going to be able to take care of the surge of COVID patients.
And so last year when fall came and as we feared, when everybody started being indoors, I think maybe a lot of schools were virtual last year at this time, but a lot of people started coming indoors when the weather got cooler. As expected, things started to surge pretty fast. Are we on a similar trajectory? Are we way ahead of that? Or what does it look like compared to last year?
Yeah, so that's one of the things I put in the handout, that we're going to be starting schools this year at a much higher baseline rate of new cases per day than we did last year. So we're at over 2,100 cases a day right now in the state. Last year we were in the neighborhood of 700 or so when we opened schools. So there's a lot more cases of COVID out there, active cases, infected people in the community as we're opening schools. So I do expect that we will see a surge, and I would expect to start seeing the numbers go up over the next 2 weeks, certainly, as more and more schools are in person and brought together. I think a lot of schools last year did open up initially, in-person training, and then there was a lot of it that quickly had to go to virtual training. And I've, in all of my conversations, I've had conversations with a number of school administrators, and my message has been just be ready to pivot if you need to, in case you have outbreaks of students, staff, if you lose faculty, you may have to pivot to some other form of education, at least temporarily.
That's all we have today. Anything else?
I don't have anything else.